Hello, everyone. Good morning, good afternoon, good evening from wherever you're joining us from today. And welcome to our Healer demo, Healer by Lecturio. Talk just a little bit about our product before we start. So I hope this is not your first Lecturio event. If it is your first Lecturio event, welcome. If you're coming back and you have participated in other events, welcome back. So if you want to learn more about Lecturio's platform features, please feel free to scan the QR code to book a walkthrough. Today, we're going to be talking about Healer. We have other products as well. So if you're interested to know more about Healer after today's demo, or if you're interested in learning about the other products, please do let us know and feel free to contact us either through the link or just through one of our email addresses that we will share with you at the end. We do have another question at the end, whether you would like a more personalized demo for your organization, for your school, for your learners, for your professors. But in the meantime, we will create one today that we'll talk and we will talk about healing. Okay, I will stop sharing here. And in the meantime, I would like us to start. So I will kind of give the baton to Dawn, and she will introduce us to Healer. I hope you have seen the Healer platform and you have used the Healer platform in the past. In case you haven't, you're in for a treat. You're in for a great ride. So Dawn will walk us through the platform now, show us all of the technical aspects of the platform, where it comes from, and everything, and then we'll go through a case. Dawn, the floor is yours.
Excellent. Thank you, Dr. Stefanovsky. So thank you again for joining us today. We're very excited to show you Healer. And just a little bit of a background about Healer. So Healer was originally developed by NEJM Group, the publisher of the New England Journal of Medicine, and is now owned by Lecturio. And I had the pleasure of working on creating Healer. So I was 4 years with NEJM Group. And then about a year ago, actually almost 2 years ago, came over to join Lecturio. And it's been a fantastic combination of having Healer as part of Lecturio because the behind the scenes that Lecturio has, all the videos, the QBank, the AI capabilities, it's really been an excellent place for Healer to be. And some of you may already have Lecturio, so Healer can actually be an add-on to Lecturio, or Healer can be a standalone. So what I want to do today is take you through the Educator portal for Healer, and then I'm going to turn it over to Dr. Stefanovsky, and he's actually going to go through a case with you through the learner application. So I like to always go back to kind of where did Healer come from? Where did this all come from? And kind of who is behind the scenes? So I like to start with the about section. So when we think of Healer, there are so many people who are involved in helping with clinical reasoning. And what Healer is a program designed to help you teach and assess clinical reasoning. So I didn't get a chance to see if you're from an NP program, a PA program, an MD program, a DO program, or a residency program. But Healer is designed and can be used for any of those types of programs. So just a little bit about kind of who is behind the scenes, who helped create Healer. You'll probably notice some really impressive clinical reasoning advisors here who we have. And really, it all started with an article by Dr. Judith Bowen in 2006. So I'm going to give you a little bit about the behind the scenes, but just know that the cases that you're using are vetted and incredible cases that, again, are for you to use with your students. So you'll be able to have the same case for all of your students, and then you'll be able to look at all the performance data as your students or learners or residents go through these cases. So again, I like to kind of go back to the where did everything come from? So in Lecturio, now again, Healer is owned by Lecturio. So in here, I'm right in the resources section. So this whole idea of how to teach and assess clinical reasoning was started with an article that Dr. Judith Bowen wrote in 2006 for New England Journal of Medicine. And what she wrote is how can you think about how does a learner learn? If you're a practicing clinician, you probably have a great idea when you walk in the room, you know to gather findings, you now know how to update your problem representation, you come up with a general hypothesis, and you're basically building a mental illness script that helps you come up with a differential. But how do you teach that process? So what Dr. Judith Bowen did is create this idea here of there are these key elements to the clinical diagnostic reasoning process. And in Healer, you'll see when Dr. Stefanovsky goes through the case, you'll see we go from triage, history, physical exam, diagnostics, and then we have a diagnostic pause, a DX pause. So what she says is that you go through the patient story, you gather findings that help lead you towards one differential away from another differential. At each stage of the case, you update a problem representation or patient note or SOAP note, and then you're coming up with different hypotheses. So what do you think the differential is at each of these stages of the case? And then the coolest part of Healer that I love is that when you get to this other stage of the case, you're actually going to be building a Venn diagram. So it's a very visual way to think about clinical reasoning. And again, in 2006, Dr. Judith Bowen came up with this idea of if you build a Venn diagram which has the top three differentials in it, this is the act of building illness scripts. So Healer is really based on illness scripts, problem representation, and really going through looking at different differentials and ranking them at each stage of the case. So you'll see when Dr. Stevanovsky goes through a case today, we'll progress through triage, history, physical exam, diagnostics. Then we'll actually do a DX pause. We'll do a management plan, and we'll be building a Venn diagram. So let me go back into our educator portal here. Uh, when we think about what is currently in Healer, and just so you know, Healer is growing. We're currently at 132 patient cases and growing. So what I did is just go into the assignment area of Healer, and this it makes it very simple for you to assign cases. So again, I'm not sure if we have people here from NP programs, PA programs, MD programs, DO programs, or residency programs, but Healer can be used for all of those. And one great way to use Healer is similar to what we're doing today, which is actually having Dr. Skevanovsky going through a case with us and assume we're a class, and he's going to be asking us to pick findings, to update our problem representation, and to update our differentials and move them up and down in the case. So Healer is a great way to go live with your class. So if you need cases, you don't have to write your own cases. You can use the current Healer's cases that we have here. And let me show you a little bit about how you would go about looking through the cases. So we have these filters here on the left-hand side. So you can filter by acuity, you can filter by age, you can filter by difficulty. So Healer can be used in your preclinicals. It can be used with didactics. It can be used as a great transition to clerkship. It can be used for OSCEs. It can be used for transition to residency. It can be used for remediation. So again, there's so many different ways to use Healer. And in here again, you would come in here to find a case that you want to use. And for today, I'll just pick, maybe I want a senior adult case, and maybe I want to look in the organ systems here. Maybe I want a cardiovascular case. But just to give you a general overview here, these are the types of cases that you see in here. You can search by presentation. All of this is in here for you to choose the cases that you want to assign. And then here, I just have two filters selected. So now I can see that there are 14 cases that match what I'm looking for, which in this case, I said a senior adult, and I was thinking for a cardiovascular case, cardiology case. So just to give you a quick overview of what you see here in the educator portal, this is the patient's name. So the case name is Riley Johnson. Abdominal pain is the chief concern. That is all that your learners are going to see. And you'll see that today when Dr. Stevanovsky goes through an assignment with you. So that's all that your learner sees. This here is a fantastic play audio summary button. So we're in the educator portal. So if you want to play this before you even assign the case, this is a 5-minute overview of the expert who wrote the case. And then your learners will see this when they finish the case. They will be able to listen to this audio summary. So here in the educator portal, I see that the final lead for this case was right here, chronic mesenteric ischemia. And then we say IS objective. So in Healer, again, what we talked about from Dr. Judith Bowen is at the end of the case, there's going to be a Venn diagram. And the Venn diagram for this case is going to have what we call the IS objective or illness script objective. So these are the top three differentials that are going to show up in the Venn diagram at the end of the case. And your learners are going to be moving findings into this Venn diagram using likelihood ratios. So that is a very large part of the case is, again, the Venn diagram. And then here, this is the final problem representation for the case. So at each stage of the case, we are tracking for you. What did your learner write for their problem representation and triage? How did they use semantic qualifiers? How did they chunk data? And again, we're tracking through triage, history, physical exam, diagnostics. And then what you see here, though, is the final problem representation for this case. So this gives you an idea if this is the case that you would want to assign. Very simple to assign cases. We've made it very user-friendly. So again, it's a 5-step process here to assign a case. And once you assign a case, then it goes to the learner application, which again, Dr. Stevanovsky's going to show you next. So just a quick overview, a little bit about Healer in general. It can be done in any language. 20 to 40 minutes per case. So it's not a very long time period, but we say 20 to 40 minutes because we don't just want them to go through a case and say, oh, I got such and such numbers or such and such feedback. We want them to really spend time going through the feedback. And when, again, Dr. Stevanovsky goes through the feedback today at the end of a Healer case, you will see how detailed it is. We really use things like probabilistic reasoning. So when we're looking at the differentials that the learner picked versus what the expert picked, we also use probabilistic reasoning to say at this stage of the case, maybe it was 20% likely COPD, but why? Maybe it was 30% likely something else, but why? And then we break that down for each stage of the case. So the story really unfolds when you're looking through the information at the end of a case. This is deliberate practice. We want to make sure that this is saving you time and saving you from having to create cases and also from having to grade the cases. All of that is done for you with Healer. And then these are ready to use. So after you've assigned cases and you've gotten the students to do these cases, then you can come in here. You can look under assignment performance. We can look by learner, by cohort, by assignment, by case, and you will see all the information that we capture. So if we are looking at a specific case, here I'll just pick on this Aaliyah Jones case here. So we can see here what we're tracking is performance overview, and I just picked by case. This could also be where you just assign a case to a student, so or a learner, so it can be used for remediation. But in the Educator portal, what we're capturing is all the information about the scoring. So again, we'll go through this in more detail when we go through a case, but we're tracking data acquisition efficiency, data acquisition thoroughness, differential diagnostic accuracy, which is what differentials they chose at each stage of the case and how they ranked them, lead diagnostic accuracy before they got feedback, and then revised lead diagnostic accuracy, which is after they received feedback from our experts. And then we have illness script concordance. So this is the act of building the Venn diagram. And now we're very excited. We're going to show you this today. We now have AI feedback on our problem representation concordance and our management plan concordance. So it's even an additional way to help the learners get more feedback on what they've done in their cases. So we also give relative performance. So if you like charts and graphs, if you like box and whisker charts, this will show you the outliers, and then you can track someone across all areas of the case. And then I'm not going to do it right now, but if I wanted to click this export button here, what I could get is an incredible CSV file, which is going to tell me how many minutes every learner took per case. What did they write for the problem representation and triage? What did they put for their differentials in every stage of the case? What did they put for their management plan? And what this export does is allow you as the educator to look at one case or one assignment and say, why in triage was everybody thinking this was asthma? Or why in the management plan did they all send this person to an infectious disease expert? So again, the export is a file that you can use to look at the overall performance by case, by learner, by cohort, or by assignment. So I'm going to stop there because I could talk for days about Healer. I love working with Healer. And I'm going to turn it over to my colleague, Dr. Stevanovsky, to actually go through a case with you.
Thank you very much, Don. And it's always incredible to see all of the capabilities and how powerful the platform is from the Educator portal side and all of this data that you can obtain for your individual learners and for your groups, because then you're not just making blanket decisions for everybody, but you're really making this almost personalized education where you can approach your learners by what exactly is needed for them. So thank you very much. That is always incredible for me to see, and I never get tired of seeing it and hearing it because it's incredible. So what we're going to do now, and I just want to thank everyone in the chat for starting discussions and introducing yourselves and everything, because then we can see your background and we can see where you're coming from. I see that some of you work with clinical patients, some do not. So hopefully this case will be useful for you, for all of us to go through it together. Feel free to ask questions. There were some questions already asked. We answer them. We will answer them by the end. So we're open to that. We'll go through a case, and what I really want to encourage is for the chat to be active, and I will try to monitor the chat as much as I can, because whenever I do a differential diagnosis, whenever I do problem representation or anything, I would love for you to also participate if you want to and if you're able to. So we'll start now together. And as Don pointed out, we have 132 cases at the moment. And the cases, you could use different filters. And some of those filters give you a more complex cases, and others give you a more cases for more novice learners. What we did do today is we chose a case for you. And we're going to look at Mr. Elias Khalil, whose chief concern is cough. So I hope you can all see my screen well. And we'll go through this case together. It is not a super complicated case. It's not a complex case. And I just took the liberty to assign this case for myself. So this is what your learners see once you assign the cases. So we are currently not in the educator, but we're in the learner portal. So as a learner, your students, your learners can come here and you can look at the assigned case. And then as you can tell, there's still no image here. There's no profile picture for Elias Khalil. Once they start the case, that changes and um, we get that image. Now I see that sharing is paused, so I'm going to try to see why that is. Give me a second. I'm trying to. Okay, I think it needs to go like that. I think you're able to see it now. So this is what you get once you open a case. Please just, if anyone can confirm that I'm sharing my screen. So it goes, welcome
Yes.
to here. Thank you. So you could start the case with guidance or without guidance. The guidance doesn't necessarily guide you through the clinical aspect of the case, but rather through the platform. So we're going to go without guidance because I will be the guidance for the day. So this is what the platform originally initially looks like. So we have Elias Khalil here, our patient, and you can see that these cases are not just their chief concern and problem representation, but they are individuals that kind of exist within this ecosystem of healer. Now, there's some general information, and we tend to click around these, and everything we click through goes into findings, right? So, for example, the fact that this is an emergency department, once I click, it tells us that one of the findings is that this is an emergency department, which in essence means that we have a case that's urgent, or it's most likely urgent given that we are in the emergency department. Now you click through everything that's positive, but you also want to click through everything that you find important. So even if something is negative or something doesn't tells you that a certain differential diagnosis is not the right one, you still want to click it. So the way that you would do this as educators is you could either share this with a class and you can be the one clicking, or you could assign this to your students so they can do the clicking. And both of these methods of education and using Healer tend to serve different purposes. So in this case, I will be the one showcasing this. And as Don pointed out earlier, we could do this as a class almost. Now, the fact that he has a cough and it's spring also could be important because of allergies. So that's another finding. We have age, we have gender and sex. Then we have things that are outside of the normal range in red. But in this case, we can see he doesn't have a fever, which is also a very important finding. We have his blood pressure being normal, heart rate elevated, respiratory rate. So we just click through everything we find important here. Now, you do have the chief concern, and there's questions preloaded in the platform. So once I click here, there will be preloaded questions with answers about what brings our patient here today. Now, if you're doing this, especially with more novice learners, and if you're doing this in a classroom, you would ideally ask your students what it is you want to ask the patient. If this is a more advanced learner where they already know how to take patient history, you will just click through, and then all of these answers are showing up. So this patient have had a cough for a while. It has worsened though, which kind of explained why the patient is in the emergency department. And then we just click through, right? Everything that we find important. So he coughs all the time, but this time is different. It is productive and it's brown-green mucus. It is worse in the mornings. It's worse this time than past times. So we have even tried cough syrup, but it did not work. And once we know enough about this patient from here, we are starting with our problem representation. Now, this is something you want to type. Now, I would invite you all to type in the chat if you want me to add anything within the initial differential diagnosis or within the problem representation for the patient. Wait, okay, I have access to the chat, so I'm able to see it as well. So in the problem representation, I'll start us off. Please feel free to add, is that we have a 60, a second, we have a 63-year-old male patient presented in the ED with productive cough. And then you can be as detailed as you want. We can say the patient is afebrile, which is important. Um, and sad. So oxygen saturation is 87. And for now, that could be enough. And then within every step, because we're currently in just triage, with every step, we add to our problem representation and make changes. Now, before we move on, we also have to have differential diagnoses. What is really important here with the differentials is we can add as many as we want or as few as we want. And in each step of the way, we need to add more depending on everything new we learn. We could remove some of them once we know that something is not the right diagnosis, or we could re-rank them. We have a question of whether the patient smokes. Once we get to the history, we'll get an answer to that question. So for the differentials at the moment, from everything that we see, we could say it could be acute bronchitis, let's say, because it is a respiratory. It could be upper respiratory viral infection, or could be a pneumonia, right? So we don't know enough right now to say which one of this is the first one, but everything we add and everything that we write here is being noted in the background of the platform. So in the end, when we get feedback and AI feedback, everything that we mention is taken into consideration. Now, when I click continue here, I already moved from triage to patient history. Now, within the history, we're going to start learning more, and then we will start changing our problem representation in our differential. So we see that he has hypothyroidism. Something very important. He has COPD, which we're just learning about. He has hypertension, never had COVID, no recent injuries, and these are the medicines that he's taking. So we see he's on albuterol inhaler. He is on levothyroxine, losartan. So he has therapy for these diseases that he has, and he is taking the treatment as prescribed. Again, this is sort of self-reported for the patient, so we can be certain he doesn't have allergies, which might be important when we discuss management. Um, and he's up to date on his vaccine. So once we do this, we have the medical history already. We go into family history. So in here we have cancer and heart disease, something that he had, and we go into social history. So we had someone in the chat asking if this patient is a smoker. This is where we get the information for that. So he is walking 20 minutes a day, but right now he doesn't because he is now has symptoms, no insect bites, and he is currently smoking 1 pack per day. So he used to smoke about 2 packs per day. Now he reduced it to one. So keep in mind, we have a patient with COPD that smokes. He's an active smoker. He does not consume alcohol, and he has a wife with mild cold last week, and his daughter had a cold the week before that. Right? So it's really, really interesting findings with this patient here that will help us decide what is next in the differentials. He went to the Middle East, but last year. Otherwise, he had not left the city. And this is really important about timing as well. He lives in the apartment right now. And then there's obviously more information like professor of mathematics, which might be important, but might not. Once we're done with the social history, we have something in the chat. Um, Yeah, so I see that in the chat there is the medical history. Important is whether he was in a hospital for cough or CSOB, smoking history, and he's hypoxic. So he does have all of these. And now we're going to go with the systems. We could do any system we want. And if you have a more novice learner, you tend to click through all the systems. But given this is the ED, we're only going to go through the systems that we consider important at the moment. So within the general system. It seems like his appetite is fine, no fatigue, which might be important, no fever recently. So he was afebrile now, but he had no fever recently. No chills or rigors, no night sweats, no change in his weight. So then we could go through everything, but let's go through respiratory at the moment. So he has been short of breath. So what we had in the chat earlier is whether he has been short of breath, which is yes. And then there's more questions of that. He is short of breath right now, which makes sense because his oxygen saturation is a little bit lower. Feels much worse than usual. And he has been short of breath for the past year, given that he has COPD and he's a smoker. But the worsening of it started suddenly. He feels like he needs more air by describing the feeling. It doesn't happen more frequently in a particular time of day. Um, and his breathing gets suddenly worse every 6 months or so. So he is decompensating at times. Um, and he feels better when he stops moving. This is everything that we saw earlier. Now, has he coughed up any blood? He actually has coughed up blood last week. It happened once, speck of blood along with the mucus. He has wheezing, also very important. He has wheezing more this week as the cough started. He started noticing this a year ago. Comes and goes, lasts as long as he exerts himself without specific timing, and it's been getting worse. And it stops when he rests. Now, this is really, really important here. What we could also look is cardiovascular if we want to before we go. In the cardiovascular, he has chest pain, which if we didn't really click, we would have missed it. So he is experiencing chest pain now with the coughing and wheezing and COPD. This could be something, but it could also mean that he has a cardiovascular event. So we don't want to miss this. The chest pain started a few weeks ago. It's in the middle of his chest. It's more like tightness that started slowly, but no pain in other parts of the body, and it's mild pain around 3. Um, no similar symptoms in the past. Coughing makes it worse, and nothing makes it better. He also feels like his heart is racing, which we also noticed in the physical within triage. We have a physical exam after this, more thorough. It comes and goes, and nothing really helps with that. He also has decrease in exercise tolerance, as we saw within his medical and social history. The decrease started 2 weeks ago, but the exercise intolerance has always been there, and it's been getting worse over time. And he doesn't wake up at night with shortness of breath, which is also important. Now, knowing what we know now, it is good for us to kind of update our problem representation here. And if anyone wants to add something, we can. But in this case, we can say that patient diagnosed with COPD, active smoker, uh, complains of chest pain, coughed up blood last week, decrease in exercise tolerance. Now, what's really important here is that I would organize this better were I to have more time. So I'm just kind of writing almost everything that I find, which is important for us for that to be noted. And we will see how this plays out when we go into the feedback. Something really important is patient noticed wheezing, and we can just add any other symptoms here. Okay. So now that we have this, I think it's good for us to kind of revise our differential diagnosis. Acute bronchitis kind of falls out because we really don't have anything suggesting that this patient has acute bronchitis, potentially chronic, but that's part of the COPD. So we definitely need to add COPD, but in this case, it's an acute exacerbation of COPD. So there it is. Something else that he might have, especially because he coughed up blood, especially because he's been tightening chest pain, is um, pulmonary embolism, for example. Pulmonary embolism, because that's an acute condition and it can cause this. We already have pneumonia, but given that he hasn't traveled anywhere, this pneumonia would be community acquired pneumonia. Which, as the better, the more specific we are, the better in the end. And now we need to re-rank this before we go into his physical exam. When re-ranking, I would rank everything above viral upper respiratory tract infection. So that's still there. It's still an option, but I would say it's not really upper when he has the chest pain. But without me assuming anything, I will just continue. So now when we continue, we enter into the physical exam, right? So we are at a point in our scenario where we can always go back to recheck if we forgot something. But at some point, when we do the differential diagnosis pause, we are unable to come back. But at this moment in time, we can. So we could go through general exam, and this is what that looks like. And everything that is going to be show up in red means that it's a positive finding. But as I said, within our findings, for us to be thorough, we need to find or note the ones that are not positive. Now, we could check anything, but any of you who has either worked or been at an emergency department, you know you're not going to be checking eyes and ears unless the patient has symptoms related to them. So let's start with respiratory in this case, given that that's the main chief concern is cough. So we look at chest wall, for example, and the chest expansion. We've done auscultation. So he has diminished breath sounds bilaterally. We see what's absent and what's present. He has diffuse bilateral rhonchi. Then he has wheezing bilateral. And then we go into palpation. So no tenderness, crepitus is absent, auditory fremitus and tactile fremitus are normal, which is important. Now, within all of these areas, all of these organ systems, I would kind of go through cardiovascular because he is complaining of chest pain. So we just want to be sure that there's nothing, no major findings in that area. And as you know, we never take chest pain lightly in the emergency room specifically or ever. So in here, we could see, what's normal and what's absent. We do palpation, blood pressure tests. Is there difference between two arms? Drop whether he's standing up or orthostatic hypertension. No change in pulse amplitude with inspiration, and there's maneuvers or murmurs over there. So from the organ systems exam, that's pretty much what I would do. In this case, I would say I'll just put PE first just to kind of move these around, even though there's nothing at the moment showing me what could be wrong with this patient. Now we go within diagnostics. And as a rule of thumb in diagnostics, we tend to learn the most. But what we want to encourage is to learn or help our learners understand that the triage history and physical exam is incredibly important. So when you do this with a classroom, you only ask the students what it is that they would order from the tests in here. Um, and in that case, you only click where you're needed or where you think that your students, your learners want to learn something. Let's go into chemistry here. So we see that in this panel, in this biochemical panel, everything seems to be normal. And in the cardiac test, this is really important. These two are normal because when it's chest pain, we want to know if it's cardiac. And this kind of tells us that it's not, most likely. In the complete blood count, we have leukocyte counts to be slightly elevated, which I would say maybe would bring P a little bit lower at this point in time, but everything else seems to be fine. And there's differential here in blood. Now, you could order CT if you want to, and this is with contrast. We see the chest wall being normal, but there's mucus noted in large airways, which is also very important. Bronchial wall thickening, really important. Panlobular emphysema. So he has COPD, so this is something that to be expected, but the panlobular aspect also tells us what this might be. No parenchymal infiltrates, no lymphadenopathy, no pleural effusions, pneumothorax or masses, and these two are really important. We have no pulmonary emboli, which is really important in this case. Just because of the chest pain, we do electrocardiogram, ST segment. There's no depression of elevation. So looking at this, I would say his heart is good. His 62 ejection fraction, which given his disease and his age is pretty well to be expected. Now we could be adding here, but in the interest of time, I would like to kind of move on to the next part, which is the differential diagnosis pause. Let me just check the chat. Blood gas is missing. You're absolutely right. And I agree with you. And I will put a pin in that because once we go into what is the management, we would add blood gases to be performed because they haven't been done, so we're not sure how it goes. Now, in the differential diagnosis pause, you're asked if you want to make any changes in your differentials. So looking at this, we could remove something, we could take this to be higher or anything we want, and then you're also asked to self-reflect. So how confident are we that it's an acute exacerbation of COPD? And let's say I think so, but you also ask how mentally demanding was this encounter? Let's say this wasn't very mentally demanding. Let's put it at a 3, maybe a 4. I'll put it at a 5. Okay. So the next part is you do start getting glimpses of feedback, right? So we're not at a point where we get feedback, but there's some glimpses of feedback. We have the top three diseases here agreeing with what the experts who created the case have done. And just in case the top three diseases don't agree with this, let's say we have community acquired pneumonia. If we only wrote pneumonia, that's going to be missed. But that being missed doesn't really cause any issues within the platform because the top three diseases are always valid and important for you to see what your learners have done. We have the data acquisition, we have a really good efficiency, or at least good efficiency, but not great thoroughness. And I would say the thoroughness and efficiency will vary depending on the level of your learners. So a more novice learners will be far more thorough, but a more seasoned learners will be efficient. And we go here, we see what it is we noted, but we really didn't have to. And is there anything that we missed? So you see, I've kind of missed all of these. The orthopnea or the lack of dysphagia, the lack of heartburn, like all of these are things that if I were to note it, my thoroughness would have been better. But all of these here are not that important for this case. It goes for the physical exam. See, I just missed so many here. Um, Within the diagnostics, see the ECG T wave being normal. I completely missed that. But again, if you're efficient and if you're more seasoned and you know if that's important at the moment, you will note it. Now we go to the next part, and this is something that Dawn really talked about here, and this is the epitome of creating the illness script. And this is my favorite part of this platform because you get the Venn diagram, but you also get to create this Venn diagram. So you have the main findings that help us understand this case. And the ones in green are the ones that make any of these three diagnoses more likely, but the red here help us distinguish or make some of these diagnoses less likely. So you can click through or you can just take them and slide them where you need them to. So let's say which disease or diseases will make this findings more likely. Hypoxemia, let's say, can be found everywhere. So that goes in, by everywhere, I mean these three diseases. So that can go there. You can also click through here if you want to. So COPD makes it more likely to be an acute exacerbation of COPD. Sore throat occurrence in days, let's say here, right? So we could really add these and create our own Venn diagram and kind of finalize this illness script. And I would say that this is the part where you can really see how your learners are thinking. Now, in the interest of time, I'm just going to take these and just put them anywhere. Um, I don't know, productive cough, let's say here. Um, right, dyspnea occurrence, let's just add it anywhere. And as I said, this is really important in the illness script because at the end, you also see how someone is thinking. Panlobular emphysema, let's put it here. And now absent rails, let's just put it there. No infiltrates, so no pneumonia, no PE, makes it less likely to be PE. So once this is created, when we've taken that pause, that differential diagnosis pause, we go to the next section. Now you have to kind of choose and say, we do know it's acute exacerbation of COPD at this point. And let's say this is very likely or probable. Now, it's really important to provide a management plan here. So what are the additional diagnostics? And this is what I said, let's put a pin in it in the chat. So we did discuss arterial blood gases. So we can say, let's do in additional diagnostics, arterial blood gases. And in here, you can be as specific as you want to. So we could test him for COVID-19, right? We can say, let's just check. Maybe that's what caused the exacerbation. Or we could just add whatever we want. In the referrals, let's say we'll refer them to pulmonology for outpatient treatment, for example. In treatments, we could add, I don't know, glucocorticoids. We can add ibuprofen. We can add IV fluids. So you could really add whatever you want. In counseling, we can say smoking cessation, because something that you all clocked at the beginning is that this patient is still smoking. The timing, let's say this could be outpatient, um, and then your degree of concern in this case could be high. So again, in here, you want your students to really write this up fully because the better they write it up, the better the feedback they get in the end. In the interest of time right now, so that you don't just look at me typing it, I'll just submit the case for review at this moment in time. Now, this is where where you as an educator really come into seeing what your students have done. When you click see how well you performed, we have AI feedback. And while that is in progress, I will just, because it takes it a minute, I will just kind of show you what we've done and what the experts have done. So nobody's expecting this to be copy pasted, right? So we have some information that I wrote in the triage, something that the expert added. We have the history, what I wrote, something that the expert added. And what you could do is have your learners read this, not expect this to be completely, the same, but this is for them to take a pause and to kind of check what it is they missed or how this could have differed. You get an overall AI feedback. So although you get a score, the score doesn't tend to tell us much because this is not to be used for summative feedback, but rather for formative feedback throughout the process of learning. If you just take the score, and later we'll see, it's possible to see how this score is how we get to this score. This part is what's really important. As busy educators, more often than not, we don't necessarily have the time to type out detailed feedback for all of our learners. And this is a really good way for them to go through and see it demonstrates a consistent approach across all sections. There are important areas for improvement, and it tells us which ones. And then within triage, it's what we included: age, sex, the chief complaint. However, you omitted key acute findings such as tachycardia, tachypnea, did not specify the acuity or chronicity of the cough, right? Something really important. And we can look at this for each section. So history, how this should have evolved, how this changed, and everything. So we do get the scoring, but as I said, this written feedback is what's really important. What's really nice here is you could also have your students, your learners, take a note of how they could have improved the problem representation. And when they write this, this is something that you can see, and especially if you're schools where you use SMART goals at the beginning of the semester or something like that, you can really see how your students are thinking and how they can improve themselves. Now we go into the management plan. So let's see how well the students performed with the AI feedback, or how I performed in this case. So I just wrote arterial blood gases COVID-19. It is there. Sputum culture is something I didn't order, but at the same time, it's really important to know that they kind of typed it out entirely. We will get feedback on it in a second, though. There it is. So we have the overall score. It demonstrates some understanding of the clinical scenario, but there are important gaps in several sections. So you could really see which those sections are and how. So first section, we included arterial blood gases and COVID-19 appropriate, aligned with the expert plan. You omitted sputum culture and a broader respiratory viral panel. With counseling, we said smoking cessation, which is great. That's what we need. With referrals, pulmonologist, perfect, but we didn't say what to do over there. So, for improvement, specify that this referral should occur after acute stabilization and include the rationale for ongoing management and pulmonary function testing, right? We have the timing here, and we have treatments that we would give. I said glucocorticoids, they said systemic glucocorticoids, which is good enough, but I didn't write anything else like antibiotics, supplemental oxygen, and everything else. So when we finish this, we can go and review the final feedback in the process. Now we get a summary report, and you can print this report and you can have it for your learners. You can have them in your file if needed. The concordance here is 98%, which is great within the illness script. And you could go through, the summary, you could go through diagnostic accuracy, you could go through data acquisition. This part in the feedback here is something that Dawn mentioned earlier. And I think that this part for learning is really important. The probabilistic reasoning is really embedded and etched in the platform here. Because as we were changing this, so we have viral upper respiratory infection, for example, we can see what the expert has done, and we can see in greater detail why certain differential diagnosis was well written, why some weren't, and what's the degree of concern for the patient. So you could really walk through this case. What's really important here is we have diagnostic schemas as well. So you could look at what to do with a patient with acute dyspnea, or what to do with a patient. I'll go back in a second, but your students, your learners can use this, even print it out and carry it with them, what to do with a patient with dyspnea, so they can then use this probabilistic reasoning within their patient encounters. Here's the data acquisition. Again, we have the efficiency and thoroughness from before. We see what was missed and what wasn't, but in here you get a greater feedback in detail, in depth. And this is something that saves you many, many hours so that you don't have to type this out for your learners, but they still get it and they still understand what it is they did right and what it is they did wrong. So again, you could use this with any learners at any point. The overall concordance was pretty high, but as I said, I was kind of clicking through. What did I miss? The wheezing. Oh yeah, because community-acquired pneumonia would give us wheezing as well. But this is pretty much good, I would say. It's 98%. And this is the important part where you see how your students are thinking. So when your students want to learn about their own thinking, and when you want to look at clinical reasoning as a skill, this is the important part where you're looking at things. There's again the problem representation here, something that we already kind of saw with AI, but you can look at one more time. And at the end, we have management plan and the scoring within that. Now, you could print the report and there is an explainer, and the explainer tells you how all of these numbers, how this concordance of 70%, how do we get to that? What is it that the platform is using in the background to really get us to this place? So as you can see, we really went through this entire case, and we are really good with time, and there's enough time for you to ask questions. But by going through this case, I hope you saw what it is, what are the options and opportunities that you can use with your learners so that you don't have to come up with your own case, but there's also so much happening behind the scenes. Besides that, we added the AI feedback where you really can have a very comprehensive approach and feedback for your learners to actually be able to learn how to think and how to approach patients. If you have any follow-up questions or you would like to discuss this in greater depth and detail, we are at your disposal. So if you enjoyed this, then you would enjoy our global webinar series even more. And the next one on Tuesday, March 31st is called How to Shift from Teacher-Centered to Learner-Centered Health Professionals Education. If you want to register for that webinar, please scan the QR code or just go to our website and you can find more information over there. But you're also more than welcome to reach us and then ask how to register. Now we have Lawrence Sherman being our speaker on Tuesday, March 31st. If you've been at an AMI conference, you have met Lawrence. I am confident of that. So if there's any questions or comments, please do feel free to reach out to us at any point and contact us at healer@lecturio.com for any healer questions, or go to lecturio.com just to see the rest of our products in Healer. If you scan the QR code, you can learn more about our products and ask for a specific demo for your institution. So I really hope that you do contact us, and I really hope that we will see you very soon to some of our other global demos series or the webinar series. I would like to thank my colleagues Dawn and Sarah. And if there are no other questions, I would give us a few 9 minutes of your day so that you can go and enjoy yourselves. Dawn, anything to say?
Nothing. Amazing job, Dr. Stefanovsky. I love that case. And again, please reach out to us. We can also give you a free trial where you can have 5 healer cases where you can try with your group. And again, we're very excited that you were participating today, and let us know how we can help you.
Thank you very much. Thank you, everyone, and have a wonderful rest of your day or evening. See you soon.